So I'd like to welcome George Daly-Smith. He's going to speak to us today about what we can learn about the causes of cancer from the risk of bilateral tumours. Thanks, George.
Cheers. Thanks. Ideal for snoozing after lunch. Especially designed.
No, that doesn't work. What do you do?
That's less motivational.
Okay, so yeah, this is the outline, so you know which bits to lose to, probably a lot. It's going to outline stuff you'll know about why cancers are, how we can know cancers are preventable in principle. One slide on risk factors and influence in prospective studies, and the rest of it is to say why they aren't going to work if you're thinking about contralateral cancers. And two possible hypotheses which actually go with what is known, as opposed to just carrying on with doing stuff that we've 40 years of failure. So that's it. So, how do we know that there are missing external exposures that are causing cancer? Maybe it's just luck, it's genes, etc. I mean, so genetics, some of you here do genetics. There was a lot of fuss about the case of missing heritability many years ago. This is when genome-wide association studies didn't instantly discover large effect genetic variants because they didn't exist in many situations, but they, of course, as the studies got larger and larger and larger, and the whole genome sequencing to find rare variants, etc., this has shrunk away, and it basically shrinks in relation to how large the sample size is. So in height, where it's massive, missing heritability really is getting small. So that's good news. But in our field, not such good news. So there's been no major advances in identifying environmental factors outside a handful for decades in the field of cancer, despite optimism. So the environment, by the environment here, I'm referring to all modifiable, non-germline genetic causes of disease, but it's not equivalent to all but germline influences of disease subtracted from the total, because there are many stochastic influences on individuals getting cancer. But which individuals within a population get cancer relates to stochastic factors which can't be disciplined. Cancer you cannot discipline. You don't have vast amount of biological data. But they, of course, will not contribute to changes in cancer risk over time, differences in cancer when you migrate from one country to another, differences between countries, because obviously luck doesn't cause changes over systematic changes over time. The missing environment has been a theme basically since epidemiologists started thinking about identifying causes of disease. This is John Higginson, who was the first director of the International Agency for Research in Cancer, who I met as a medical student. Thought he was a boring little man. I wish I had known what I did today and actually had asked him lots of questions, but I didn't. Anyway, so Higginson was looking at differences between populations in South Africa, but then talked about that hypothetically all populations could have the lowest rates seen in either American or Bantu populations, or the highest rates, and the things between them were things that were preventable. And he said, we're in possession of the techniques to identify many of these causative factors given time, and then, of course, complexity and money. And this was really codified in this remarkable volume by Richard Doll and Richard Pito, commissioned by the US Congress to investigate the causes of cancer. And they put together data on time trends in cancer risks changing over time, going up or going down within populations. Clearly, genetic changes can't lead to changes in cancer over time. Migrant studies, people who move from one population to another, and then does their risk and their children's risk change to the population they move to? And so those geographical differences are largely not going to be accounted for by genetic differences, and then by identified causes. Identified causes meant arsenic and cigarette smoking, essentially. Anyway, and using the data from those sources, they estimated that around 80% of cancer were preventable in principle. That meaning that if the population had the risk that existed in a sort of low-risk population where you have really good data, and then you could reduce the risk to that, you could reduce cancer by 8%. And only about a third of those were the causes known, and causes known about smoking, asbestos. So they speculated on the causes of the avoidable in principle cancers, basically using ecological differences between places with high and low risk, things that appear to have changed over time. And they thought that diet was going to prove to be the real major driver of cancer differences, with tobacco, of course, being by far the best established factor contributing a lot. So that was speculation, and they thought studies could be set up that would model on the very successful prospective studies of smoking, and would crack these causes. Indeed, Richard Doll in 1977 said, "I see no reason why the causes of the remaining common cancers should not be detected. The remaining common cancers, a lot, could not be detected in 1 or 2 decades." So, but I mean, that was a reasonable, really reasonable sort of thing to say, seeing those very large differences in telling us that there must be modifiable causes, there must be things that could be changed. Richard Peto wrote a piece in Times Health Supplement, didn't exist anymore, in 1981, about why cancer. And despite the fact that he repeated the large figure about diet, he did say, in the study of diet and chronic disease, all we know for certain is we don't yet know very much for certain. So this is obviously speculation. At the same time, Richard Doll and others wrote a brilliant paper in Nature in 1981 about dietary beta-carotene and human cancer rates, and it was looking at, it was triangulation of evidence at its time, putting together data from cell systems, from animal studies, from human studies, including a natural experiment in Brazil, where the carotene levels changed because the oil people consumed changed, etc. All that evidence together and said, this looks like something worth betting on. And it was bet on. There's a large number of trials were done. The only paper I've ever seen in Nature which had a caution put under it said, unwary readers, if such there are, should not take the accompanying article as a sign that the consumption of a large quantities of carrots needs to wait for more evidence. And the evidence came from the randomised controlled trials, and all now trials that are lasting up for over a decade, randomising to large amounts of beta-carotene, no effect on cancer. If anything, a slight increase in lung cancer. And of course, we've seen that story play out again and again and again and again. Things which observational epidemiological studies identified as the best, by far, these are the strongest candidates. People are not going to go out and spend hundreds of thousands and millions of dollars on trials for things which do not look like they've got the best evidence. So all the other things, all from the Nurses' Health Study, of course, all the other things the Nurses' Health Study has found, including trans fats, by the way, which people somehow religiously believe in. The evidence is no better. It is worse than the evidence is for these things. It's just a change of policy. So, and anybody who wants to eat crap logic, that's a sad situation in epidemiology. Anyway, Richard Doll in 1998 said, in 1980 we asserted that in principle it should be possible to reduce the incidence of disease in middle and early old age by 80 to 90%. Since then, there's been lots of accumulating knowledge, but it's not translated into anything. But there's been loads and loads of molecular biology. So we've done lots of molecular biology, but we haven't got anywhere in terms of preventing cancer. And for the sort of 40-year anniversary of the publication of the Extraordinary Reports of Cancer book, Paul Brennan from IELTS and I have created the analysis. The reason it appeared after 41 years is because I'm always very slow and always delayed the more assiduous people like Paul. Anyway, the bottom line is you do the same calculations now with way, way better registration data, then it's still 80% of the cancers available in principle. And remarkably, the proportion of preventable in practice hasn't changed. Anyone think why that's not changed? We have learned some things. We've had HPV vaccination. We've got H. pylori identified.
Is there a difference between finding a cancer and people dying of cancer? That might have changed, even if the finding of
this
cancer.
is all based on incidence, not on that.
All right.
No, it's because smoking has fallen. I mean, if you want to be in a country where you can prevent a lot of cancer, just have a high rates of smoking. And because smoking has decreased, there's less you can blame on smoking. And in fact, amongst non-smokers, the much higher percentage is not. That doesn't have causes. So the proportion that can be prevented with what we know hasn't changed. And as I say, we've had big successes like HPV and H. pylori, HPV and cervical cancer, and immunisation is obviously brilliant. H. pylori and stomach cancer immunisation might be brilliant if anyone develop a vaccine. So these are the population attributable fractions, which shows that in never smokers, you explain about we know the cause, about 25%. In smokers, 50% smoking. Okay, so that's what is preventable in principle. So a large proportion, there's a big chunk of cancer that is preventable in principle, but that factors that can prevent it aren't being identified. Now, stay right at the beginning. There's nothing special about cancers of bilateral organs like breast cancer, kidney cancer. What's been said about them is almost certainly going to be true of other common cancers. It's not that they're particularly non-preventable, it's just that because you have a paired perfect control of the contralateral organ, that you can see these things which make it clear that certain things can't be identified as causes. Again, Richard Doll in 1967 had remarked that women who develop cancer in one breast have a higher risk of developing cancer in the other than women who were previously unaffected, but the excess risk is small. So, we consider kidney cancer. So when you think, then the overall standardized incidence ratio for the second primary, if you develop kidney cancer in one kidney, is 2 to 10. And different studies will come on to the differences, but generally on the smaller side. It's higher at earlier ages, where there are some obviously high risk genetic syndromes or conditions, but it declines to less than 2 at older ages. The absolute rate differences depend on baseline risk, as they always do. And the standardized incidence ratios for secondary cancers aren't remarkably different according to baseline population risk. So what happens is if you're 30, which is very young to develop parenchymal kidney cancer, which is extremely rare in that age, then you have a high relative risk, but the absolute risk doesn't change as you get older. So by the time you get to about 60, your risk in your other kidney remains no higher basically than the population, just any kidney, choose any kidney from the population. So that's pretty remarkable, seeing as they're matched perfectly on germline genetics, and they're matched for every exposure. I'll go on to a few exposures that we can't tend to be matched on, but they're obviously matched on smoking, both kidneys are influenced by when you smoke, alcohol consumption, exercise, etc. And you end up with this this remarkable, just absolutely fixed risk that your other kidney will develop cancer, which some have interpreted as saying that you're basically just one step away from them developing cancer, because then it's just a toss-up with a weighted coin every year. It's just a toss-up with really got one sort of step in the other kidney. Now, there's a huge number of data issues, and it's very messy data. Because of it, for breast cancer, there's a vast amount of data. So, I mean, firstly, how many organs at risk? If you've developed cancer of one breast, then for most studies, they only consider contralateral breast cancer. So you've only got one breast at risk. So you shouldn't be compared to the general population risk levels of people with two breasts, because there are two breasts at risk. So that's got to be taken into account. The different disease types are the disease types in the contralateral tumour the same, and they're not, which is in itself interesting. The synchronous versus metachronous second primary. So synchronous is when they're both detected around the same time. And of course, you get a big blip in synchronous cancers when someone's diagnosed cancer on one kidney, one breast, because there's extensive investigation to detect whether they have cancer. The studies usually consider synchronous as detected within 3 months of the primary, although that changes in different studies. So you have increased surveillance, then you followed up, you have increased mammography, for example, if you've had cancer of one breast. Treatment can have an influence, either positive or negative. In the case of breast cancer, you get tamoxifen, that reduces the risk of you developing contralateral breast cancer. Preventative therapies, including prophylactic mastectomy, and the data in most different countries with high cancer rates. Consider breast cancer. Of course, there's established individual level risk factors like a greater age of menarche to first birth interval, lower parity, late age of menopause, lack of breastfeeding, possibly genetic influences, obviously HRT and all contraceptive use, alcohol consumption, body size. But of course, all of these risk factors will influence both breasts to the same extent. There's no reason why there'd just be a left breast influence of lower age of menarche, for example. So they should influence both. So breast cancer is definitely is very much preventable in principal cancer. There's now good data from lower middle income countries. You see a sort of 3 to 4-fold difference across large country groups. You see that the sort of for countries with reliable data, 5-fold difference. So is the difference. But that's a very substantial difference in absolute rates of disease, and if any of that could be prevented, it would have a major impact. Now, with breast cancer, unlike kidney cancer, there's vastly more data. And I think the sort of paper which drew attention to this difficult to understand issue with contralateral breast cancer also reported data on the non-affected monozygotic twin. This is a paper by Julian, Pito, and Mack about the high constant incidence in twins and other relatives of women with breast cancer. And what this it had a family-based linkage, and it looked at what happened to people who were first-degree relatives of someone who was diagnosed with breast cancer at age X, and then it looked at their risk, plotted their risk from age X on. And what you see is obviously with the younger the age of onset, like diagnosed at by 30, then obviously they're more likely that high effect sized genetic risk variants are shared, or other family history factors. But what you're seeing is that the risk in the first degree relatives is basically just a constant level of the sister's risk at the time, sister or mother's risk at the time they develop breast cancer. So these are first degree relatives who are not, who obviously aren't matched on the exposure. And then whilst it's not been as extreme, and it's been still very large, the incidence in the patient's other breast is half of the incidence in the patient's MZ twin, because the MZ twin has two breasts at risk. But this is, the MZ twins, of course, matched on very early life stuff, which is very interesting, and sisters are matched to some extent on factors in earlier life, less so in later life. So that's been the twin stuff. I won't go into that, but it's been seen in much larger studies. So now the overall standardised incidence ratio for second primary is again about 2 in breast cancer, and it's related to the age of primary cancer, as in kidney cancer, which then leads to this near constant absolute risk after diagnosis of the first primary. And this is a larger follow-up study involving Julian Peter with a much larger Scandinavian record linkage system, and what he showed was that this is people who have family history of breast cancer and get breast cancer in one breast, and then this is the cumulative incidence over 20 years of developing cancer in the other breast. This is a non-familial breast cancer, and your risk of developing cancer in the other breast. And this is if you have a monozygotic twin. It's not double, but it's still a monozygotic twin with two breasts has a higher risk of developing primary breast cancer, first breast cancer, than just someone who has developed breast cancer and therefore has achieved some sort of threshold level of exposure to actually develop breast cancer. And the dizygotic twin sister still has elevated risk to the population, but low risk. And in a recent massive study from the US, this constant risk is seen with contralateral second breast cancer. This is all ages. That is all ages, and because with the younger the onset, the more likely people are to carry high risk genetic variation. The actual absolute risk is higher for people who are developed this at younger ages, the cumulative risk, people who develop at older ages, but the sort of pretty flat, constant risk is seen for up to 20, 25 years. So if you consider that against the age distribution of breast cancer incidence, then of course the younger age cancers are relatively small, considering the area being occurred. The younger age cancers are a relatively small proportion, so the ones which have some sort of strong genetic driving are a small proportion of the total cancers. And then, perhaps sort of most remarkable of all, is that the risk in the remaining ipsilateral breast tissue is similar to that of the contralateral breast. So people have surgery, generally will have surgery, there'll be be some reduction. So you actually just take the sort of volume of tissue that is at risk, then the risk is the same to that in the contralateral breast. This is the tissue adjacent to that. These are now the second primary ipsilateral breast cancers from that. You can see it just looks exactly like that. It's just the same as the contralateral breast cancer. Now it goes very strongly against one sort of popular theory, one popular current theory, which is the field cancerization notion, is that when you develop cancer in a tissue, then local tissue to that will have undergone changes from which that cancer has emerged. People interested in tissue-like environments talk about this very frequently. There's extensive literature on this. This was December last year from the American Journal of Human Genetics. These are meant to be nice visual abstracts. It's very easy to understand, but the bottom line was they took tissue. They took tumour tissue and tissue from what appeared to be normal breast tissue in the same breast, and then looked at various features of that and came to the conclusion that there was evidence of tumour microenvironment in that tissue that reflected field cancerization, and which relates to the process. Of course, that makes no sense with respect to the contralateral breast has exactly the same risk as the ipsilateral breast. I mentioned earlier that basically the high-risk genetic effects that you can see through BRCA1, BRCA2, the relative risks for that are actually less in order to give people to look at for the contralateral breast. So you're thinking that there's a large amount of risk that exists in populations. But if you think of any risk factor you can think of your study, who's looking at causes of breast cancer, dietary factors, etc., fighting as well. Virtually every factor that you can think of, the contralateral breast will have been exposed to it to exactly the extent to which the breast which developed cancer had. And yet what happens is that if you look within the population, and you consider that you've got a population of 1,000 people, which is a population of 2,000 breasts, the breast which is matched perfectly for genetics and for exposure to a breast which has developed cancer has only mildly elevated risk compared to a randomly chosen breast in the population. Now, what factor can cause that? What potential? Think wildly. What factors could lead to that situation? Do you think that's a sensible situation? Is that a situation that just seems carry on business as usual? Carry on giving the questionnaires?
Treatment for one cancer reduces the risk of the other.
So it does, but what that led to is actually the risk of contralateral breast cancer now if anything falling even lower, just becoming lower than just a random breast selection in the population. I've got a slide at the end on that for tamoxifen. Yes, the tamoxifen treatment reduces the risk of developing cancer, but that is it's to think of any exposure. So, there's a couple of possibilities. One is that the exposure is something that the populations, this population with 5-fold difference in breast cancer, that at the extreme, you think everyone in the population, the high-risk population is exposed, and no one in the low-risk population is exposed, or something like that. Because then you won't, if everyone's exposed, you can't see individual difference. You cannot see between individual differences if everyone has exactly the same exposure. So we could have a sort of thought experiment, which is quite an example, but which is about thinking about hypothetically in Bristol and Bath, where you imagine that 70 years ago there was a dictator took over in Bristol and said everyone had to smoke 20 cigarettes a day. You were not allowed to go to bed until the CCTV cameras that you got given packets of Capstan full strength, and until you'd inhaled the last of your Capstan full strength, you were asleep. So everyone in Bristol has to smoke 20 a day, and then in Bath, the dictator said no one can smoke at all. And in Bath, of course, it's posh, so that's no one can smoke at all. But, and then, so that's it, exactly 20 cigarettes a day, 1, 0 in another. And then you follow them up for 70 years. And Bath will have, Bristol will have 20 times the rate of lung cancer as with Bath, obviously. But within Bristol, you do a study of lung cancer in Bristol, everyone smokes exactly 20 cigarettes a day. You can't detect that smoking causes lung cancer in Bristol. And then what causes one individual rather than another to get lung cancer? People will say genes, but lung cancer is heritable, as 20% heritability, but and has a shared environmental effect which relates to smoking, but most of the variance, featured variance, is non-shared environment, which just means stochastic noise. It's basically luck, which largely, but you certainly couldn't identify, very difficult to identify factors that were influencing risk in Bristol. The one way you could do it is with Mendelian randomisation, of course, because you could use the CHRNA5 variant, which leads to people smoking more heavily. So those on 20 a day will actually get more rubber, more nastiness out of the cigarettes, and will have higher lung cancer risk. So that's a model how one can study ubiquitous explosion. But between Bristol and Bath, everything's caused by smoking. So you have, at a population level, you have an exposure that can be responsible for nearly all cases, but account for a little difference in risk between individuals. So that's the situation we might be in. Maybe smoking was an unusual thing in that it was very easy with a questionnaire to identify who was smoking, and you had people who didn't smoke. So you actually had differences. I mean, interestingly, in Dole and Hill's 1950 case control study of hospital-based case control study of lung cancer in men, 96% of the controls were ever smokers. Because smoking really was virtually ubiquitous for people who came out of a society who came out of the First World War when drugs were given to all the soldiers. Ubiquitous amongst men. So we think, if we think of the kidneys, and you think of every exposure you think of, fruits and veg, smoking, alcohol, exercise, lack of exercise, or trilene, which when I was a medical student was still used as an anaesthetic for pregnant women. It was used during childbirth, but it's now a registered carcinogen. There are all these exposures, but for most individuals, the difference between individuals is stochastic. These kidneys are perfectly matched on all of those exposures. I mean, of course, they are unilateral risk factors. I mean, trauma is unilateral, there's therapeutic radiation, and actually for breast cancer, I mean therapeutic not for the cancer, but therapeutic for something else, like Hodgkin's disease or we radiated on one side. Well, for people who had conditions where they were radiated on one side and not the other, in the United States, there was then an increased risk of later breast cancer. It was small, but it existed. But the may be much more careful about dosages, etc. Cosmic rays, this is for breast cancer, this has been suggested why air hosts have a high increased risk of breast cancer, but they're not plausibly major influences. So if you consider pairs of kidneys in two populations within which exposure levels are ubiquitous, you can imagine that each pair is obviously one individual, but you can treat this as 2x kidneys, and you can, if you have phenotypes, you can partition the variance, so you actually get the amount of variance for any factor. You can look at, you get the variance which is within individual and then the variance which is between individual. The bottom line is you're just thinking that you hope that something can generate what one sees in contralateral tumours. The obvious mathematical answer to it is that the variance is between individuals. Sorry, the variance that you're seeing is between population. So you have between individual, within individual, between individual, in one population, and then here you have the populations with a fivefold risk than the other, but where the vast majority of the variance in the exposure is between population. And of course, the methods we use in epidemiology are largely focused on within populations. So we have big studies on UK Biobank of middle class elderly folk, and we look for risk by looking for between individual risk when maybe things like lung cancer and some other conditions, the ones that we actually identify things for are the ones in which there are large individual differences, and between individuals is actually a big component of that. That's actually I think tamoxifen, but it's gone. Anyway, so that's one hypothesis. I think that's the most likely. And these aren't mutually exclusive. I think the ubiquitous exposures hypothesis is the most likely one. It means that cancer epidemiology should focus on thinking about the sorts of exposures which are ubiquitous within populations, but can have differential outcomes. And one class of such exposures, well, there's obviously environmental exposures everywhere, chemicals, stuff in the water, air pollution, etc. Where not everyone will be identically exposed, but it's very difficult to think of methods to actually measure individual level exposure for doing that. But that's why the bilateral organ situation is so marvelous, because that is like a sensor. If you want to get something which senses, that somehow manages to sense all these exposures which cause breast cancer, then someone having developed cancer of the other breast is a very good marker of what that breast is exposed to. So we need to think about, we should at least think about exposures that are ubiquitous. The second, I call the hit and run hypothesis, and that is that you're not looking at exposures like agent monarchy, which then change your risk after that, or exposures like the germline genome, which influence your risk from conception, from fertilization onwards. You might think of something which arrives and goes and temporarily increases your risk, but only while it's there. Now, there's one of the fascinating things of working with ridiculous amount of data that there are on bilateral breast cancers in particular, is that there's always noticed this fact that there's a lot more synchronous cancers, i.e. ones diagnosed around pretty much around the same time, or when one is found and the other one is developed, are more than you would expect, just taking the weights into account, and then that wears off. So the studies usually they'll always exclude ones that where you identify a bilateral contralateral tumour at the time of the first tumour being seen, and then they'll usually exclude ones that appear in 3 months, for example. You can get enough data to show that there's more than you expect, a lot more than you would actually expect, and it could be this ridiculously intense surveillance, but if that was the case, you'd expect the survival to be greater of the contralateral ones, even greater, detection even greater than it is. You know, there's been sort of suggestion that the Epstein-Barr virus infection has a genetic effect, which is also related to methylation effect, which has a sort of large effect in a tiny proportion of people, and a small proportion of people on risk of breast cancer, and will generate synchronous tumours. And it isn't incorporated into the genome in the way that Epstein-Barr is incorporated into the beta cell genome. It's not incorporated into the genome. So these things could be exposures which arrive briefly, change the risk for the whole body of initiation, which will become real around about the same time. So that's one possibility. You know, they could be dramatic promoters. And the tissue, but throughout. So that's a hypothesis. In terms of the ubiquitous, for both sort of hypotheses, and one thing that's learned from what has been learned about cancer, the risks that have been identified since Donald Peters since 1981, they're infections, hepatitis, human papillomavirus, H. pylori, etc. And one very obvious category of exposures that are literally ubiquitous, but could have different impact on people, are exposures, are viruses which everyone gets. Everyone gets Epstein-Barr virus, but it's just a matter of the age you get it. And the age you get the virus can have a very dramatic effect on the outcome. If you get the virus as an infant, you won't even if you seroconvert while you're in a study, it won't largely be noticed if you can get sniffles. You know, if you get it when you're 16, you have increased risk of glandular fever, infectious mononucleosis, and that is basically a sort of post-viral fatigue syndrome. If you get it at 25, you've managed not to be infected by the age of 25, a remarkable study in US conscripts is about the biggest relative risk. Well, in season epidemiology, you have about 25, 30-fold increased risk of multiple sclerosis. So the infection is literally ubiquitous. Everyone is going to get infected, but the age at which the infection comes about differs. So those are the two sort of hypotheses. So extensive evidence on contralateral cancers calls into question the effectiveness of conventional immunological approaches, entirely in line with many decades of failure. Business as usual will probably be fine with respect to funding agencies, publications, but perhaps not with respect to improving population health. And favourite novels, Thomas Pynchon's D, So he says life's single vessel that there's more accident to it than man can ever admit to in a lifetime and stay sane. That's on the reading. People were saying, particularly Isaac Allen, who did an amazing thesis at Cambridge on data from Paul and Caroline, who are about all these issues. Jane Ferry collected those data for me. Julian Peter, who I spent one time 20 years ago in a bar talking about this. I've never remembered it ever since, but we've always got very worried about it. Doing a little work earlier. And there's a few papers which cover some of this stuff. Richard's brilliant 1977 papers, which I read from the IJEs. Most recommended. That's it.
George, any questions?
It's interesting going right back to the old Peto days. But they didn't have exercise or physical activity. That didn't seem to feature in it in a sort of preventative sense at all in them days.
Yeah, that's an interesting point. They definitely sort of thought about it because, of course, exercise is like, it's one of the sort of good things. It's a sort of grandmother's thing, isn't it? That's most of British academic studies. Some of the things your grandmother said was good, like eating vegetables, and doing exercise was good for you. That sort of thing. The issue they had, and what's really is fascinating about it, was that, of course, at that time, studies of body mass index did not show large effects on cancer. And indeed, low body mass index was, observationally, low body mass index was a risk factor for developing. Well, probably it was a risk factor because it was an indicator of the early stages of the condition. But they did sort of mention in passing in the book, and I think in the chart, I can't remember I think they did put somewhere something about obesity, but it was like obesity was like 1%, and now that's something that's dramatically changed. And I mean, of course, the studies, if you do the studies just naively, the studies do show that lower body mass index does relate to higher risk of lung cancer, head and neck cancer, esophageal cancer, etc. It's just that there have been, obviously other approaches like MR show other results. But again, that's definitely, it's extraordinary how you hear people make these statements about people, heavier people get more cancer, but actually observationally, it's not that much the case. And I mean, and something like colon cancer, where people just declare that this is so much related to adiposity, the actual evidence of some of these things are weak. In fact, probably the best evidence in my there is on something with a dramatic effect is larger preconverted body size and lower breast cancer risk. Something that replicates across designs, including randomization. It's a very large effect. It's not, and it's always it's amazing. You just read these. Yeah, exactly. It's just not discussed.
Yeah, fantastic. It was making me think and reflect on the many couples that I have seen that are diagnosed within a few weeks or months of each other. And we always put it down to, well, you're going to be heightened awareness.
Yeah.
But it just made me think, in your reading, has there been much done on household contacts? And because these are not old people that are getting diagnosed.
Yeah.
It's not uncommon for us to say, oh, I'm looking after you, and their significant other is being treated at exactly the same time. I mean, I've had quite a number. I was just looking to see if there was much literature on it. I just wondered what your thoughts were.
Yeah, no, that's really interesting. I'm sort of interested in sort of spousal pairs in biobank. And Lawrence Howard wrote a paper about what can you learn about risk of the other spouse from one. And it's of course it's difficult to decompose the contribution of sort of associative mating. I mean, as I say, you can use Mendelian randomization, for example, shows that couples who get together, alcohol you're associatively made on alcohol. People who have genetic variation related to drinking more tend to end up with people who have genetic variation related to drinking more. So you have this there's all those issues in there, of course. And then there's obviously the sort of shared environment, obviously household environment, etc. So it's a sort of underused, or it's understudied sort of issue, I think, because people think it's just too complex. It's just impossible to separate all the different contributions.
I'd like to see that paper. You have to show me that paper because we always just dismiss it. But it's, and these are not just the older. It is people in their 50s and 60s. It's weird.
I was just, sorry, you go. I was just going to ask about, sort of between population differences. Then should we be doing studies that are more global and talk about cross ancestry stuff in head and neck, new cohorts that we're opening up? But then the risk factors are different as well. It's I think about head and neck specifically, fetal chewy, that kind of thing going on in different regions, Mate in South America, things that are quite bespoke that wouldn't, necessarily show us. But I guess it depends on the cancer you were saying as well. Some would be within individuals, some between populations. But should we go more global or?
So I think that this is in a way what studies like the IARC standard, other group prominence studies, etc., are doing. In that case, actually, precisely because of this sort of thinking about ubiquitous exposures. Is sort of about time, but it's thinking the studies they do with mutation signatures is seeing whether those mutation signatures might actually relate to exposures that are geographically distinct. So we're explicitly looking for such exposures. For example, in a sort of recent kidney paper, they had a mutation signature that was basically exclusive to Japan. Japan has a higher rate of kidney cancer than it should, assuming sort of East Asian ancestry and environment. And now they're actually going out and looking for sort of which is widespread in Japan, but isn't seen in other parts of the world, including Thailand, Taiwan, etc. So I think the direction is to think about actually having an ecological element to studies. If you think that you're looking at exposures that are basically concentrated within geographically distinct regions, then you should actually go out and explicitly look for collecting drinking water samples. It's really easy to get people to just look at that tap. Collect things which actually are not measuring individual level risk. You explicitly go out and collect ways of measuring population level risks. I mean, the problem is the sorts of things that get pointed to, if we went to chemicals are extremely difficult, are difficult to study. But if it's something that is measurable and identifiable between individuals, at least at the large studies, at least sort of start pointing towards it. And the remarkable thing is the absolute lack of anything.
My question was going to be about using mutational signatures to understand ubiquitous risks.
And I think DNA methylation is also something that as it's been a good indicator of smoking and arsenic, can be powerful, but particularly if you get tissue-specific data. So again, the IR groups are doing are collecting autopsy samples, but including samples from abattoir samples from animals. I've had back to come out to that TV department, but I had a picture of their collections that are being made of meat, basically, in areas which have high risk of renal cancer, to try and look at using this markers of exposure. So you've got to think of other ways of data collecting than calling half a million people in and taking the blood pressure and cholesterol level and asking them whether they eat sausages.
So, your lung cancer thought experiment have suggested that maybe the secret to identifying the missing environment is actually to use germline genetics. So your example about if smoking is ubiquitous, you could in principle use Mendelian randomization to identify that smoking is a cause, because there will still be inherited variation in how people respond to smoking. So like extending that to, say, infectious diseases, everyone could be exposed to viruses, but people will have inherited variation in how they respond to those viruses. So maybe what we need to do is we just need to take the genes that have been, the germline genetic factors that have been mapped to cancer. We just need to work out the pathways through which they are working, and then that will be one strategy to identify environmental factors.
Yeah, no, I agree absolutely with that, and I think that's a sort of powerful reason if many more were needed for multi-ancestry studies. Is looking at, if you're thinking that the population's the level of exposure, you would then expect to see, for example, for metabolizing enzyme polymorphisms, if you see the same effects in one population and not another, then that might give you clues on what factors you should look for. Because the thought experiment with smoking and lung cancer would be in Bath. The CHRNA5 variant wouldn't relate to lung cancer in Bath when no one smokes. It doesn't relate to lung cancer in people who don't smoke and aren't exposed. So so that's definitely that's what we're saying in that European Journal of Epidemiology piece is that makes the case for using a few interactions as well as finding out.
But it also suggests it's a way to, in a way, save the conventional within population approach. Because if you have a population where everyone is exposed to the cancer-causing factor, there will be between individual variation in how people respond.
Exactly. Yeah.
I guess, doesn't it also suggest that, like, if you're going to stick with the observational approach, you need to be much more specific about sampling greater exposure variation, right? Like in the BAP example, like if you had a population where people's cigarette smoking ranged from 0 to 100 a day, you would be able to detect that.
Yeah.
But we would go much more proactive about going out and sampling, like collecting primary data that has a greater range of variance in terms of the exposure. We might be able to still use the same observational epi approaches.
Like cotinine.
I think you'd want more geographical. You'd like to have more geographical range as well. But
yeah. I don't want to just do it in BAP.
To think about how that can be done, but also to think about basically sampling on the basis of disease in this given population. I was going to say, we're always told when thinking about your exposures in epidemiology, you're always supposed to think about the within and between variation. So maybe we could just add sort of an additional level to that to think about. You want some variance which isn't all dumped in one category.
Anything online?
Just taking a
trying to store these matrices and ideas for testing.